Welcome. We're going to talk today a little bit about screening and genetic testing. As I see who's on the list, I think everybody knows who I am. If you have any questions during the presentation, please feel free to unmute your computer and ask away, okay? So we'll go ahead and get started. So I first have to do a disclosure. I am a member of the Speakers Board of Genomic Health who developed the Oncotype DX test, which I may mention during the presentation, but I will likely not. So what is this all about? Well, this is about 1 in 9 women in the United States who will develop breast cancer in their lifetime. So this is a very high number. It is interesting that the incidence of breast cancer is different in different racial groups. So the highest incidence of breast cancer is in white non-Hispanic females. Hispanic females actually have a 30% less incidence of breast cancer than their white counterparts. And between age 40 and 50, African American females have the highest incidence of breast cancer, along with the highest incidence of the very aggressive triple negative forms of breast cancer. Korean females have the lowest incidence of breast cancer of any of the racial groups. Despite the fact that the overall number of women that develop breast cancer is higher in white non-Hispanic females, the overall death rate for breast cancer is significantly higher for both Hispanic and African American females. Now the question is, how can we impact on that? So the big thing is education. So we want to educate people regarding screening, prevention, risk reduction, and multimodality treatments. These are all going to decrease mortality from breast cancer across all racial and socioeconomic groups. So screening. Why? Why do we screen? So the data has been clear for many, many years that women who undergo routine screening have a 40% decrease in their mortality from breast cancer should they develop it, versus women who do not undergo screening. And this applies to all groups. Screening is generally going to find tumors when they're small and non-palpable, likely stage 1, which are much easier to treat than tumors that are found on palpation, which are generally going to be stage 2 or higher. Interestingly enough, it's conservatively estimated that the delay in screening that has occurred in the last year with the coronavirus pandemic will lead to an additional 5,000 deaths from breast cancer over the next 10 years. And that's a very conservative estimate. So just think about that. Not being able to screen for the months that we were locked up at home is going to cost more people their life than the people who died in the Twin Towers. So why quantify risk? Well, for several reasons. First is, if you know the degree of risk, you can justify appropriate screening. Documenting the degree of risk can also alert patients to needs for a lifestyle change. And we now have specific interventions that can be used to decrease the risk for breast cancer if we know that a patient is in a very high risk group. So what are some risk factors? So we're first going to talk about non-modifiable risks. These are things that you can't do anything about. Hormonal things like the date that you started your period, the date that you stopped your period, the age of your first live birth greater than 35 is a risk factor, and women who have no children at all do have a higher risk for breast cancer. Also, family history, which everybody is acutely aware of. A primary relative, that is a mother or sister with premenopausal breast cancer, is a very high risk marker. 2 or more close relatives, and by that we mean anybody within 3 generations. So that would be obviously mother, father, sisters and brothers, aunts and uncles, grandparents, and cousins. So to add 2 or more of any of those relatives with a history of breast, pancreatic, prostate, or ovarian cancer, that is an increased risk marker. And women of Ashkenazi Jewish origin. So I'm the only Catholic guy in the world that knows this, but 7 million Jewish women are in the United States, and of that 7 million, 6.5 million are Ashkenazim. So if you are Jewish, you're most likely to be Ashkenazi. Radiation exposure, women who have undergone radiation therapy for Hodgkin's disease. Anatomic features like dense breast tissue. I do want to comment on this because this is a little bit overworked. Everybody who gets a mammogram gets a report back that they have dense breast tissue. That's because there's a law that they have to put something on the piece of paper that discusses the density of the breast tissue. All young patients have dense breast tissue. So by definition, that can't be a risk factor in a younger patient. But dense breast tissue that is persisting past menopause is likely related to increased circulating estrogen levels, and increased circulating estrogen levels are felt to be a risk factor. So dense breast tissue counts more in patients who are postmenopausal than it does in patients who are premenopausal. There are some pathologic features. If a biopsy is done by your gynecologist and one of these things comes back, these are important things that should be discussed with a breast cancer specialist. So if ductal carcinoma in situ, which is not truly breast cancer, but cancer cells within the ducts, lobular carcinoma in situ, something called atypical ductal hyperplasia seen on either biopsy or cytology. And the highest risk is in patients who have a primary relative with premenopausal breast cancer and the finding of atypical ductal hyperplasia. There are now some newer things that we're seeing on core biopsy that we need to be concerned about. Atypical lobular hyperplasia is one of them, and something called flat epithelial atypia. These things are all considered increased risk factors, although they are not in and of themselves cancer. There are, however, we know some modifiable risks. And this is the part of the talk where everyone needs to pay close attention, because these are things that you can do to decrease your risk for breast cancer and prevent increasing your risk from breast cancer. So the big thing that everyone talks about is obesity. So if you have a BMI over 31 and you're postmenopausal, you increase your risk for breast cancer by 30 to 60%. That's a huge number. We're going to talk about the gradations of risk, and it'll make a little bit more sense, and I'll talk about it then, but it's important to try to keep your BMI less than 30. And the reason is that this is related to increase in circulating estrogen levels, because estrogen is stored in adipose tissue, and also increases circulating growth factors. In addition, being Italian, I'm not going to tell you not to drink. A glass of red wine a day is a wonderful thing, but we don't want you to have 3 glasses of red wine a day. This also would likely increase circulating estrogen levels. Low-risk patients can easily have 1 to 3 drinks weekly without having any impact on breast cancer. But even patients who have developed breast cancer, we advise them to try to limit their alcohol intake. Smoking is another risk factor that can be modified. If you start smoking before you begin your period, that's a significant increase factor, but it's even more significant if you start before you have your first child. Hormone replacement therapy is a difficult nut to crack because hormone replacement therapy makes women feel better, and we know that. The problem is that if you take estrogen plus progesterone for more than 10 years, this is an extremely high risk factor for breast cancer, increasing the risk by 75%. But this risk will disappear 5 years off of therapy. So we tend to try to recommend 5 years maximum, don't go to 10, and try to get off of it as soon as possible. Decreased activity is a separate risk factor from obesity. So obviously, decreasing activity increases your risk for obesity, but sitting for more than 3 hours, regardless of your BMI, is an independent risk factor for breast cancer. So you don't want to watch the whole football game without going to the kitchen and get something to eat. And if you're going to go out to the movies, make sure halfway through the movie you go get some popcorn, because you don't want to sit for a long period of time without moving around. And what about risk analysis? Well, we want to know what a patient's risk is so that we can determine what things that we can do to impact on that. So this is a list of the no-brainers. So if you have a primary relative who's got breast or ovarian cancer, obviously you need to have an idea of what your risk is. If you've not had any children, or if your first pregnancy occurred after age 30, again, you really want to know what your risk is so that you can take advantage of some of the things that we have available now to decrease risk. But the reality is that everyone should know what their risk is. So what we're going to do is stratify the risk using the modifiable and non-modifiable risk factors. So there's a nice little model, it's very simple to use, called the Gale model. And these are the things that we need in order to make the calculation. So age at first period, age at first live birth, race, family history of breast cancer in a primary relative, or 2 or more secondary relatives, the number of breast biopsies for benign disease, and if there's been any evidence of atypia on biopsies. We put all this into a cute little calculator that you can get off online very easily. If you go to Google and you Google Gale risk model, you will get about 2,000 hits. Look for the one that says NCI on it, and it'll show you exactly how to do this calculation. So once you've made the calculation, we want to stratify the risk. So average risk is going to be women who've had no children and a calculated lifetime breast cancer risk not greater than 15%. Elevated risk is going to be a Gale risk model calculated between 15 and 20%. Some of the things that are going to impact on that is biopsy-proven atypical ductal hyperplasia, lobular neoplasia, one first-degree relative with premenopausal breast cancer, 2 or more second-degree relatives with premenopausal breast cancer, or a history of hormone replacement for greater than 10 years. Those things in and of themselves are going to put you in an elevated risk group regardless of what your risk calculation is, but the risk calculation is a very handy tool to see where you are. And then we have our very high risk group of patients, and those are the patients who have been previously diagnosed with breast cancers, who have either of the in situ cancers, have atypical ductal hyperplasia with a first-degree relative with premenopausal breast cancer, and their Gale risk calculation greater than 20%. If they've had a history of breast irradiation or a history of a BRCA1, BRCA2, or any of the other alphabet soup mutations that we're now looking for, all of these are going to put patients in a very high risk group. So how does this impact on our screening? So if you are at average risk, despite what the Washington Post and the New York Times say, you need a yearly mammogram after age 40. I'm not going to digress and get into the idiocy that comes out of the Washington Post or the New York Times regarding breast screening. They have had a thing about breast screening for many years. They have no data that backs up their recommendations other than the U.S. Preventive Task Force, which I call the U.S. Preventive Task Farce, who actually also had no reason that had any clinical backing to recommend mammograms after age 45 every other year. So we're just going to go with what works, and that's a yearly mammogram after age 40 every year, and reassessing the Gale risk model every 2 to 3 years or as the situation changes. Elevated risk is 15 to 20%. We're going to ask those patients to have an annual clinical breast evaluation, a yearly mammogram after age 40. Pay close attention to your family history, because if there was someone in the family who developed breast cancer at a young age, then we would want to start your screening 10 years younger than that patient. So suppose Aunt Sally developed breast cancer at age 45. We would not want you to begin your screening at age 40, but rather at age 35. We don't go below age 25, however. Also, in patients in the elevated risk group, we want to look towards things that could decrease risk, like discontinuing hormone replacement therapy. Considering some drugs, tamoxifen and raloxifene are used for risk reduction. Tamoxifen in a premenopausal patient, raloxifene in a postmenopausal patient, but this can actively decrease your risk by 50%. And we want to start looking in this risk group about whether or not we should do formal genetic testing. And then we have the very high risk group. These patients are with risk greater than 1 in 5, greater than 20%. We want these people to be seen by a breast professional that knows how to do a breast examination every 6 months. They should also have diagnostic mammogram as well as MRI yearly, separated by 6 months. These patients, we would strongly recommend the use of a chemo-reducing agent like tamoxifen or raloxifene, particularly if their risks are getting up into the 30 and 40% risk group. The drug raloxifene postmenopausally will decrease the risk for breast cancer by 50%. And so if your risk is 40%, well, let's go make it 30%, which is clearly above 20%. If you go on the drug raloxifene, that will cut the risk to 15%, which brings you down to average risk for breast cancer. So these drugs are very important and should be considered in patients who have a very high risk to develop breast cancer. Genetic testing should be discussed if there's a family history. And again, if you have a patient and you know that one of their relatives has had a positive genetic test, but they have not been tested themselves, we should treat them as if they are BRCA positive and do high-risk screening with MRI and mammogram, MRI beginning at age 25. And in the setting of a positive genetic mutation, we want to consider prophylactic oophorectomy and prophylactic mastectomy. Again, these are interventions that decrease the risk for breast cancer. There are some new modalities on the imaging side. Sorry, I went one too far. Operator error. There are some new modalities, tomosynthesis, which is not as new anymore. It's been around for a while. And these are three-dimensional images. These should be used in all younger patients. As patients become postmenopausally, there's not as big an advantage. This is the type of modality that will pick up estrogen receptor positive tumors very easily and very quickly. It's a little bit more difficult to see certain types of cancers, but we do recommend it for all, basically for all patients now. Computerized whole breast sonography is something that is being studied as a screening modality. Handheld whole breast sonography has not been shown to be very effective because it's too operator dependent. There's nobody available locally that's doing computerized whole breast sonography. Molecular breast imaging is also something that's been talked about for the last 5 to 10 years actually, and that would be adding a contrast agent to increase the sensitivity of mammography, sort of like a mini MRI, but is still not available locally and still in its developmental stages. So let's talk now for a few minutes, and I think we're going pretty good here, about genetic screening. So who do we refer for genetic evaluations? So if there's any member of your family in second, third, or even fourth generations who are known to have a positive BRCA1 or BRCA2 mutation, that patient should definitely be referred for genetic counseling to decide whether or not a genetic test is indicated. Younger patients who develop cancer, breast cancer under age 50 or under age 55, if there's a limited family history, should be referred for genetic counseling and probably genetic testing. And any patient who has had 2 primary tumors with the first diagnosis less than age 50. The triple negative breast cancers, which are highly aggressive, diagnosed in anyone under the age of 60, we also recommend genetic testing for them. And any person, if any member of the family has a history of ovarian cancer diagnosed at any age, we also recommend genetic testing for them and any close male relative with breast cancer. And also we use the rule of 2s. If there is breast cancer in 2 relatives or pancreatic and prostate cancer in 2 close relatives, we want to consider genetic counseling and or genetic testing. Women of Ashkenazi Jewish descent with any family members at all, we also want to do that, recommend genetic testing for them. And patients with these 2 syndromes, Cowden's and Lee-Fraumeni, which I do not know a lot about, so I'm going to get off this slide before someone asks me a question. Unaffected individuals with family history, obviously it's the rule of 2s. If there are 2 relatives in the family or anybody with ovarian or males with breast cancer, these patients should consider undergoing genetic testing. So what do you do if you get a positive genetic test? Well, first thing you want to do is you want to do our high-risk interventions that we've already talked about. So screening mammograms yearly in addition to mammogram. We also want to do a bi-yearly physical examination. The next 2 things that we talk about are sometimes very difficult, particularly for younger patients. We do want to talk about doing a prophylactic oophorectomy because women who carry the BRCA1 or BRCA2 gene basically have 25% of those patients who develop breast cancer don't die of the breast cancer but die of ovarian cancer. And so it's very important to consider oophorectomy after childbearing. So usually we want to do this between the ages of 35 and 40. The act of oophorectomy itself also decreases the risk for breast cancer by 50%. We also want to talk about bilateral prophylactic mastectomy. Again, some patients ask, well, why should I prophylactically remove the breast? Why not just follow carefully and if something happens, then intervene? Well, the problem is that what the something is that could happen could be a highly aggressive form of breast cancer. And although if found early, the results are usually very good, the treatment to get to those results is still not something that most people would want to do. So prophylactic mastectomy is something that should be considered, and studies have clearly shown that women who do carry a positive genetic mutation, their overall survival is improved with prophylaxis as opposed to increased surveillance and treatment once a cancer is identified. One would say, well, why don't we just use these drugs that we talked about, tamoxifen or raloxifene, or one of the aromatase inhibitors to decrease risk? Well, the problem is that it does decrease risk, but it decreases risk mostly in the patients who develop endocrine-rich types of tumors, which are the non-aggressive types. And women who carry the breast cancer gene oftentimes get the more aggressive forms that aren't going to respond to these drugs. So what can you guys do? So the most important thing is education. Everyone should know what their risk is. Once you know what your risk is, then you can talk about getting appropriate screening, because screening saves lives. There is no question. There has never been any data that has shown that screening does not save lives. You also want to make sure that if you do have the misfortune to develop a breast cancer, that you obtain the best care via a multidisciplinary breast cancer treatment center. You don't want to just go this alone. There are some lifestyle changes that can be made to decrease the risk of breast cancer. In some elevated and high risk groups, if you are able to check all of those boxes that we talked about that decrease the risk for breast cancer, 30% of patients in those high risk group can actually nullify their risks, and their risks actually turn out to be the same as the general population. So it's very important to pay attention to those lifestyle changes that we talked about. So what are they? Obviously, you want to get out of the chair and move. Walking as little as an hour a week can decrease the risk for breast cancer. And it also obviously helps in keeping your weight down. You want to decrease alcohol intake. Average risk patients, 3 to 6 drinks weekly. High risk patients, 1 to 2 drinks weekly. You want to keep your BMI less than 31. And if you smoke, stop smoking, and encourage young women not to start. Stop hormone replacement therapy. I know this is hard. People are very uncomfortable as they go into menopause, and hormone replacement definitely makes women feel much, much better. But it comes with a cost. And if you use the combination hormone replacement therapy, that can increase your risk by as much as 75%. So try to hold it under 10 years. 5 years is better, and the effects will go away after 5 years. Prevention, risk reduction, early detection, and multidisciplinary breast cancer treatment using nationally accepted standards all play a role in optimum care. Having said that, I am going to plug our breast center here at Holy Cross Hospital. We are one of only 19 certified centers in Maryland, and we were the first certified breast cancer treatment center in Montgomery County, and I'm proud to say that we are now the only breast cancer treatment center in Montgomery County that has been continuously certified by the American College of Surgeons for 10 years. We have a dedicated group of physicians who use the NCCN guidelines as our treatment guidelines to treat all of our patients who are diagnosed with breast cancer. We have state-of-the-art medical imaging technology here to diagnose breast cancer, including mammography, digital mammography, dedicated ultrasound, stereotactic breast biopsy, and breast MRI. And our radiology department here is certified by the American College of Radiology as a center of excellence. Our radiation treatment here is also par none, one of the best in the area. We have a semi-monthly dedicated breast tumor board, which actually before the pandemic had a virtual component, and we continue to do so with CMEs awarded for either virtual or in-person attendance. If you want to get the link for our tumor board, which happens every second and fourth Friday of the month, you just need to contact Brenda Willett, and she'll be happy to send you the link. We have an outstanding pathology department, a magnificent cancer nurse navigator, our angel, Mary McCarthy, who most of you know. And our tumor registry is also outstanding. Okay, so if there are no questions, you all go on, have a great day, and hope to see you around Holy Cross Hospital.